So we're going to be talking about the Rathke Cleft cyst. And in order to understand the pathologic cyst of the Rathke's cleft, you have to know what the normal looks like. And so the normal embryology of the pituitary gland, it's a combination of neuro-ectoderm, which is going to form the posterior pituitary, and surface ectoderm, which is going to form the anterior portion of the pituitary. So you got an outpouching that occurs in the surface ectoderm, and that thing is called the Rathke pouch. And then you got a descending neuroectoderm that's going to meet at the pituitary gland. And so you've got an infundibular stalk, a posterior pituitary neurohypophysis derived from neuroectoderm, and an adenohypophysis developing from the surface ectoderm. This space is a potential space between the two pieces of the pituitary gland, and that thing is called the Rathke cleft. And so a cyst can form right in the potential space between the meeting point between the surface ectoderm and the neuroectoderm. And as the cyst grows and grows and grows, you might get a suprasellar cyst that can compress the optic chiasm. And so it can present to us just like pituitary adenoma with junctional scotoma tracheae, optic neuropathy, bitemporal hemianopsia, or if it's pressing on the optic tract, the homonymous hemianopsia. So a Rathke's cleft cyst can look like craniopharyngioma, which is a piece of cranio, neuroectoderm, and a piece of pharynx, surface ectoderm. So sometimes the differentiation between the Rathke's cleft cyst and the craniopharyngioma can be difficult clinically and radiographically. But the differentiating feature is the Rathke's cleft cyst is a cyst. And so it's got a lining that is making the cystic fluid versus craniopharyngioma, which has a solid and a cystic component and often calcified, multilobulated. So usually it's not that difficult to tell the two apart, but the histopath is what confirms that it's a Rathke's cleft cyst. The Rathke's cleft cyst is benign, and as long as it's not symptomatic, you don't have to do anything about it. But if it's causing vision loss, compressing the optic apparatus, the treatment is surgery.